Evening, everyone. Thanks for joining us this evening. My name is Jamie Jackson. I'm a registered nurse at St. John's Medical Center. I've been in charge of the orthopedic program, joint and spine, for the last 15 years, and it's been my pure pleasure to work with Dr. Christopher Hills, who's going to be speaking to you tonight. He joined us 8 years ago. About 8 years. Time flies. He's going to introduce to you some ideas of what's new in spine surgery, augmented reality, what the new technologies are out there, and how they can help with spine surgery. So it's my pleasure this evening to introduce Dr. Hills. He's a talented surgeon and all-around great guy. So enjoy the presentation.
Thank you, Jamie. I'd like to welcome everyone in this venue. It's not common that you speak to an empty Center for the Arts, but grateful for the technology and the opportunity to have you join us this evening. I apologize for those who were planning on tuning in about a month ago when we were first scheduled to have this lecture, but unfortunately the COVID bug caught up with me, and so here we are a month later, and grateful for this opportunity. Thankful for St. John's Health and the opportunity to do this, and for the Center of the Arts providing this environment for us to be able to do this virtually. I would have to say, though, that if you're joining us this evening, you're probably getting pretty desperate in terms of the streaming and with COVID and running out of things to watch. And if you're tuning in tonight with us, you're probably kind of at the bottom of the barrel for your watch list and your streaming service. And so, nonetheless, we're grateful for you to join us, and hopefully you learn a little bit about what's new in spine surgery and can take something away from it. And please feel free. We've had some people send in questions, and we'll address those at the end. Kind of the process for tonight, I'll go through a little slideshow and introduce some of the topics. We'll have a little video presentation, and then I'll have an actual live demonstration of augmented reality spine surgery here this evening, and then we'll have a little question and answer period at the end. So without further ado, we'll get started on a little lecture series here. So to start off, just by way of introduction, as Jamie said, I've been in Jackson for 8 years, and we were just talking as I got started that since we've been married, my wife and I just celebrated our 25th anniversary, and since we've been married, we hadn't lived in any place longer than 5 years between college, medical school, and then I spent some time in the military. We've now been in Jackson for 8 years, and that's the longest we've been in one place since we've been married, and so it's really been neat to see the 8 years have flown by. The picture on the left is 2010. At that time, I was still in active duty Army, deployed in Afghanistan, and those were the kids. And then to think this past summer on the right is now have 2 kids in college, a senior in high school and a sophomore in high school. So it's amazing where time goes. And in ways, COVID has really slowed time down. In other ways, it's sped it up. So it's been an interesting time frame during the last couple of years. I've been very fortunate in my training through medical school, the military, and so forth to have the opportunity to go to a lot of places. I did medical school in Arizona, just by way of introduction for my background. I did my orthopedic training in the Army at Fort Lewis, Washington. That was with Madigan Army Medical Center, which is a picture on the middle of the right of your screen. That's outside of Tacoma, Washington, and that was in conjunction with the University of Washington program. After the residency, I spent 4 years as active duty orthopedic surgeon in the Army stationed at Fort Benning. And a picture on the left there is the Army gave me an all-expense paid trip to the Middle East, to the desert there, and the young lady on the left is probably the patient that's had the biggest effect on me in my life. She is a young girl that was brought to me by Marines that were out in the field and saw this girl that had a tumor on her knee, and they brought her to me, and that's her father there next to me, and just an incredible young lady that went through a lot and really had a big impact on me. On the upper right of the picture was an opportunity I had to do some training for spine and orthopedic residents in Uganda. That's in the city of Kampala. There's a national hospital there, and there's a spine institute, if you will. It was just really a small facility that some of my mentors at Duke University, where I trained for spine, started a spine program. And that was done a number of years ago, and they now have 2 full-time spine surgeons at this hospital in Kampala, Uganda. And so I had the opportunity to do some training there for their residents and fellows. So that was a great opportunity. What brought me to Jackson was the opportunity just to take care of patients that had similar interest, and obviously the great outdoors that are here. Picture on the right is a few years ago I had the opportunity to do a triathlon in Florida, and the patient in the white shirt was a gentleman that I took care of. He was a retired colonel in the Army and had an injury sustained in an Ironman triathlon that I took care of him for his shoulder. And then just a few years ago here in Jackson, a gentleman that is a world-renowned triathlete had a lumbar surgery, and this was his second race after a multiple level lumbar fusion, and he was back racing. He actually did an Ironman shortly after his surgery, 5 months out, which was not recommended. But this was about 9 months after his surgery. He had completed a second Ironman 9 months after his lumbar surgery. On the left is a young lady in the wheelchair. She was, not this past summer, the one before, was on a mountain bike at Teton Village and had a crash and had a complete spinal cord injury with a fracture. And she spent her 14th birthday here at St. John's Health in the ICU after her surgery for her spine fracture. And I had the opportunity this last summer to go out to Wisconsin where she lives and do an Ironman there, where she and her family do support for the Ironman. And so that's a picture of her beating me in wheelchair basketball, which she is in a league now in Milwaukee. And the picture on the bottom left is her providing run support for the Ironman. And just an awesome opportunity to see her a year later from her injury coming back. Just a great attitude and a great inspiration for many spine patients. So tonight, the reason we're here is to talk about some of the new technologies in spine. And in particular, we're going to talk about augmented reality and how computer navigation is used. Computer navigation in and of itself is not a new technology. It's been around for a couple of decades. But the ability to really make it user-friendly and accessible to many people on a much lower cost and whatnot has been recently become available, and it's been a great advancement in spine. When we talk about spine surgery in general, there are really 2 things that I do as a spine surgeon. Number 1 is what's called a decompression, and that's where we take away elements of the spine to make more room for the nerves. And then there's the bigger surgeries that I typically do are what are called fusion techniques. And that's where we make multiple bones grow into one to stabilize the spine. So typically, fusion surgery is done when there's instability of the spine. And that instability can be in forms of a bone slipping on one another. It can be in the forms of a scoliosis, like you see on this image here, where the spine is curved. Another form of instability is with trauma, where you have a fracture and you can have some instability of the spine from that regard. Most of the cases that I will be using augmented and computer-assisted navigation is for instrumentation for fusion. Now, navigation is really in its infancy, putting what are called pedicle screws in place, which are the screws that connect the rods and connect one segment of the spine to the next, are really what we're using navigation for now. But as this technology grows, we're going to use it more and more for even things such as decompression, where we're using instruments to show us how close we are to the nerves. We'll be able to use preoperative planning, where we get a CT scan before surgery. We can show how much correction we can get by using templating on computers, and then we can take that into these navigation systems and be able to take our preoperative planning and execute it in the operating room to really get reliable results in realignment of the spine. And so these pictures just show how a case that I did not long ago, where the patient had a scoliosis. I do a minimally invasive technique where we put all these instruments, this hardware in through small incisions, and then we use instruments to put the rods and screws in place through small incisions. Like on the right-hand side is a picture of a patient that had a fracture that I did this technique on to stabilize the spine. And currently, when we do this without navigation, I use X-ray guidance. And to put in a single screw, many times I may take 5 to 10 fluoroscopic images to guide the instruments into the spine. And even with that, the accuracy sometimes is not perfect because you can have quite a bit of deformity of the spine and can be difficult to pick up on an X-ray system, which is just 2 dimensions, the actual location of that screw. And so navigation is allowing us to see real time where that instrument is going into the spine to allow, much more accurate placement with a higher safety profile. So again, computer-assisted spine navigation is used to track instruments to be able to see exactly where they are at live time in relation to where we want to put them in the spine. We have the ability to make 3D images of the spine to be able to capture in multiple views the safety profile of that screw, and it has increased the accuracy and safety of the spine procedures. Additionally, as I mentioned, many times we're taking multiple images to get just one screw in place, and we may be putting dozens of screws into a spine, and over time that adds up to a lot of radiation exposure, not so much for the patient in and of themselves, but for the OR team, the surgeon, my assistant, and all those involved in the operating suite. So over time that obviously has health concerns. One of the rate limiting factors in computer navigation is being able to have CT imaging of the spine. There are some modalities now where you can get a CT scan before surgery and use that to bring into your planning, but for the most part we're limited to being able to obtain CT scans intraoperatively. When I trained at Duke, it was one of the first facilities in the country that had a built-in CT scanner, but it was dedicated to only one room, and so you had to have a special OR bed that was fixed. It had to be calibrated to a CT scanner that came out of a big closet, and it was just very cumbersome and was cost prohibitive for most facilities in the country. And so advancements have come along to where we have intraoperative CT scanners now that are mobile, but as you can see on the left-hand image, they're quite bulky and difficult to work around, and still the cost is quite significant. As we come to the picture on the right-hand side of your screen, we now have fluoroscopic type, what are called C-arms, that work both in fluoroscopy, which is just a mobile X-ray, but can also provide CT-like imaging to provide 3D reconstructions of the spine. And we've had the augmented reality system at St. John's Health now for a number of months, but we weren't happy with the current offerings of the fluoroscopy machines that provide these 3D imaging. And so we just recently got a new system that just became available this last year, at the end of the year, and we are the first facility in the country that's married this GE fluoroscopy 3D image system with this augmented reality system to give us CT-like imaging, but at a lower price point with less radiation than a typical CT scan does. So we really feel it's an excellent marriage, if you will, between the newest technology to provide the best in terms of cost effectiveness, lower radiation, and the usability of a fluoroscopy machine that can be used not only in spine, but in most orthopedic procedures and others. So it's a great benefit that we just received this technology. So as I had mentioned earlier, that navigation has been around for some time. It's not widely used, however, and that's because of a number of challenges. Typically, for navigation, you have the instruments that you navigate that have to be seen by a camera system with monitors that are in another location. So when you have surgery going on, you have multiple people around the table, typically a surgeon, an assistant, anesthesiologist, a scrub tech on the back table. And so by the time you get a camera that has to see your instruments, it's very cumbersome because you're trying to navigate and see the instruments going into the spine, but if someone gets in the way of the camera, you lose sight of what's going on. Additionally, as it shows in this picture here, the surgeon is looking around their corner or somewhere else to try to see what's going on in the image while the patient's down in front of them, and it's, three-dimensionally, it can be tough at times. The young generation probably have no problem as they're used to the gaming and whatnot, but older generations that aren't used to that have a difficult problem, and there's a much higher learning curve. And so in general, navigation has not been widely consumed throughout the spine world. However, with this new navigation system, it's definitely becoming more commonplace and will continue to be the cutting edge technology that will continue to grow. So with that, there's a very brilliant engineer that took the benefits of augmented reality. He added the technology of headset retina display, such as in the military that's used, and combined that with 3D navigation of the spine. If you take all those three modalities and add them together, which has been done, you get what's called the XVISION from Augmented. And so what this is just that. We get the CT-like imaging, or a CT image of the spine that's downloaded in a computer system that then displays that 3D model on a retina display right there within a headset. So we can, and the camera is built into the headset, be able to see the spine and navigate real time. And I can see through the skin that 3D model that's been computer generated on my retina display. So it, in a sense, effectively gives you an X-ray vision to be able to see the spine through the soft tissue and see all the anatomy that's critical to placing these instruments. So what is XVISION? So it's the first augmented reality system to have FDA clearance. And as mentioned, we take that CT data that's been developed from from the fluoroscopy machine, or that intraoperative CT. It's computer generated and be able to project it right onto the retina display. And that gives us multiple data points. It gives us 2D imaging, two-dimensional imaging. So there are times where I still do open spine surgery where I could still see the spine through the incision that I've made. And at that point, I can turn off the 3D reconstruction. I can see through the retina display because it's transparent, just as those fighter pilots are flying. And so but then I can still see the two-dimensional imaging. It shows where the instruments are going, and I can look at the spine itself. If I'm doing what's called a minimally invasive case where I don't make a big incision and I just want to work through the skin, I could turn on that three-dimensional mode where I can see the spine underneath the soft tissue and still have those two-dimensional imaging to confirm exactly where everything is going real time. So the system is very basic. It has just a few components. The wireless headset that has a camera built into it, so I don't have to worry about line of sight from people getting in the way of a camera. It has a built-in light if I ever need to do an open procedure and I want to look straight at the spine. It's battery powered. And then we just have a workstation that's there that can be run by the OR nurse, circulating nurse, or a tech that's available that will help run the system lifetime there during the case. There's no cameras that are needed, not a lot of bulky instrumentation, so it's really beautiful that it's portable. I can use it in any operative suite at St. John's Health, and it's not like back in the days where I was at Duke University, where we were confined to one room where this big monstrosity came out of a closet to be able to do the CT scan, and all the instrumentation was built into that one room. So it's great to have a portable system that we can use in any room, just very flexible and dynamic process. So as mentioned, this work tower it shows exactly what I'm seeing in my headset. And from that work tower, I can do some planning, as we'll show on the demo here shortly, how we can plan exactly where I'm going to put the screws into the spine, and I can plan that out before I do any work on the spine just from that workstation. You can see here in the middle picture, it shows the two-dimensional objects. It shows the spine from the side in what we call cross-section on axial imaging, and then it shows the 3D model of the spine, so we can plan all those screws out and see exactly where the instrumentation is going and execute it according to how we like to plan it. And then we can drop virtual screws once we actually plan it. Once I put a screw in place, we can save that image on the virtual computer system, and so I can match that on the other side to make sure the screws match in nice parallel fashion. And there's times where there's a lot of deformity to the spine that can be very tricky, and so this allows us to see exactly real time where I'm placing the instrumentation. So with that, the XVISION is essentially a X-ray vision, if you will, of the spine that allows me to use computer navigation lifetime see-through 3D imaging and solves many of those problems that's been traditionally the issue with computer navigation, meaning the line of sight, the ability to still look right at the patient as I'm doing the procedure, which has enabled the much shorter learning curve and is going to have a much wider adaptation to improve spine safety and outcomes for patients. So with that, next will be a little just video presentation to walk you through how it's done, and then following this, we'll have a demonstration. So when I do this, my PA also has a headset on, and so as long as one of us is looking at the spine, we have that imaging available. And so it's very nice that you don't have that line of sight issue. Here's seeing that two-dimensional imaging of the screws going into the spine. And as you navigate, again, it's showing the spine underneath the skin in this image. And we're doing navigation to get the instruments right where we want it. We do a little pilot hole to be able to get the trajectory for the screw. And then from that, you follow the screw right into that, that trajectory that you planned. So with that, we'll go ahead and do a little demonstration on a model here. Let me put this to the side. So at the beginning of a surgical case, the surgical tech will register all the instruments. And so this is all set up by the time we're ready to get started on the case. And so again, if you can imagine, we have a patient, there's no incisions made. Even before we do anything at this point, I can mark exactly on the skin where I'd like to make the trajectory for my skin incisions. So you can see here, it's showing the two-dimensional imaging. As I look down to the spine, I can see the three-dimensional object, the three-dimensional image of the spine. And so I can essentially get my trajectory in what's called the pedicle screws, are screws that come in from the back of the spine into what the bone called the pedicle and into the front of the vertebral body. And that's the fixation we get. So the little hole in the middle of the spine is the canal, and there are important structures there. And so before I even make an incision on the patient, I can have the person managing the tower say, okay, I want to put a screw right in this trajectory. And so they can drop that virtual targeting guide, if you will. I can remove that instrument and it saves that trajectory. And so I can do that at each level and then come back and just make a very small incision. And at this point, we want to put a screw in place. And so then I can make a very small incision. I can go in and see that previous trajectory that we had, and it will give me the green light to show when I'm in that same trajectory. And so I'm coming into the pedicle, and you can watch lifetime as I introduce that instrument into the spine. And so I can change the trajectory. I can know if I'm aiming too close into the canal, I can see that lifetime. If I'm aiming up toward the disc space, the disc is the place between the cushion between the bones. And so it gives me that lifetime feedback with significant accuracy to 1 millimeter, which is a very great, is very high tolerance. And then also it shows the width of the screw. I could change that and program that in, and it also gives me the length. I measure all of the screw lengths out preoperatively, but this just gives me a double check of the lengths of screw. One of the things with navigation, it's obviously much more accurate, and so I can get as big a screw as possible in without what's called a pedicle breach, or a breach of the screw where it's outside of the parameters of where I want it to be. So the bigger the screw, the wider and the longer the length, the better the fixation. And so I can really maximize that with this computer navigation. So with that, I get a screw track that comes out. It's very simple, just to have a pedicle screw ready. I register that. So I get the OK, and we have the screw size set, and we save that trajectory previously, and so I can just follow that same trajectory down. And at this point, I can navigate, and as I put in the screw, you can see it go lifetime into the spine. And so at this point, I like that position. I confirm that, and I'll tell the assistant to mark that, drop that screw. I take off the screwdriver. That screw is still in place, and so then I can match that accordingly on the other side and do that at any level I'd like within the spine. And at that point, then I'd be able to connect the rods and set screws and move forward with the remainder of the procedure. So with that, James, anything else? James is with us tonight from Augmented. Appreciate him being here. And anything else from your standpoint? Great. Okay. It's kind of different not having an audience to get feedback from. But at this point, we will go ahead and turn it over to some question and answers. We've had some people send in some questions prior to the presentation, and we'll address those. And if people have is there a way for them to send in questions at this point?
I don't think we have a live feed right now for that, but if you have questions, you certainly can reach out to the office or myself at St. John's, and we'd be happy to answer any further questions you have. Dr. Hill's office number is on the screen there for you as well. But just to kind of start out, if someone's having lumbar spine surgery or spine fusion, you hear about all different kinds of approaches to the spine. Anterior, posterior, what do those mean? What do you utilize?
Yeah.
And what are the benefits?
Great question. So again, typically when we're doing a fusion of the spine, it's for spinal instability. So there are a lot of different ways to do spine fusions, and it can get very confusing. There are all these acronyms in spine fusion. T-lift, A-lift, L-lift, O-lift. They all stand for different approaches to the spine. So there's anterior approaches, there's approaches through the side, there are approaches through the back. And so with that, there's not necessarily one wrong way to do a spine fusion. There are benefits or pros and cons to different approaches. There's definitely been a push over the last decade or so to really do a lot of what we call anterior column work. Anterior column is the vertebral bodies in the front of the spine. And we've learned that you can get much more correction by working on the front of the column of the spine, and that's where the largest bone surface area is, which is much more reliable to get a fusion. Additionally, you can do a lot of powerful correction to the spine with implants in the front, and you don't rely as much on just screws and rods in the back. So many times I do what's called a 360-degree construct, where I do minimally invasive approach to get the implants in between the vertebral bodies, and then the screws are just kind of a belt and suspender type fixation to where they provide some stabilization while all the fusion takes place along the front. And so it's been shown that minimally invasive surgery lessens infection rate, it has a lower blood loss and slight earlier mobilization and less pain. And so with minimally invasive techniques, we can create improvement in spinal alignment, much like old traditional surgeries where you take down all the muscles in the back and do a lot of correction from the back, but with much higher fusion rates and less blood loss, lower infection.
Interesting. So if I've been told I need a spine fusion, but I'm holding off as long as possible, what are things I can do to prepare my body? What is helpful for the spine as far as a prehab or conditioning yourself?
You bet. There are not a lot of indications in spine surgery for emergent surgery. There are a few red flag things if you have progressive weakness, bowel or bladder difficulties, obviously if you have a trauma and you have instability, but most spine surgeries are elective, particularly for degenerative things, degenerative conditions. So with that, you want to optimize your health and go through conservative treatment for most conditions of the spine. Conservative treatment means anything from weight loss, physical therapy, chiropractic care, acupuncture. There are a lot of different modalities that you can use. Many times we go through injections because many injections can calm down inflamed joints. They can help with nerve pain. Ultimately, it's if those conservative measures fail is when most spine surgery occurs. So at that point, there are still other things you can do before surgery to help, what we call prehab. Physical therapy can work on core strengthening, body mechanics. There are many times that there are other conditions that can lead to increased back pain if you have a bad hip or leg length discrepancy. Studies have shown that if you're a diabetic and you have poor blood sugar control, that's important to manage because it increases your risk for infection and lower fusion rates. Nicotine is an important factor in healing. And so a number of years ago at St. John's, we developed a spine program that really helps track and monitor all these metrics to have patients have the best outcome. And it's been shown, type glucose control, certain body habitus and weight, doing prehab in certain conditions, nicotine cessation, doing all those things can help maximize the outcome and function for patients after spine surgery.
You talked a little bit about cortisone injections or steroid injections. How many times can you get a steroid injection? And do you have to wait a certain amount of time between injections or a certain amount of time after to have surgery?
You bet. Great question. So it used to be that a lot of insurances, to include Medicare, would require that patients would go through so many injections prior to allowing surgery to take place. That's not necessarily the case anymore, but still, injections are a powerful tool in conservative treatment for spine conditions. With that said, there are a lot of different conditions that can be treated with injections. Most of those are cortisone. There is some research being done now on stem cell treatment, PRP, and a lot of different of those modalities. Most of those are still considered investigational. Steroid injections have been around for decades with a lot of data on them. If you're a young patient, when I say young, let's say 50 or 60 years or younger, injections are used infrequently, usually 1 or 2, and if you're not getting significant relief with an injection after a couple of injections at that age, then typically you stop doing injections. As we get older, injections are typically used for stenosis. Stenosis is just narrowing around the nerves. Many people get good relief that can last months with a steroid injection. However, with that said, we still typically do not do more than 2 or 3 in a year. Sometimes you stack those close together, but typically if someone is needing more than 3 injections a year, it's usually beneficial to just go ahead and treat that condition.
Okay. And if I'm deciding, okay, I'm going to do that spine surgery or that spine fusion, and I need 2 levels of my back fused, they say, what's the hospital stay like? How long am I going to be there? And then what about the recovery? How long to feel normal again and get out doing things I want to do?
You bet. You bet. So traditional spine surgery, when I was in training, it was not uncommon to have a patient to say anywhere from 3 or 4 days to a week or longer, even just for a single or 2-level fusion. With minimally invasive techniques now and the technology advancements that we have very little blood loss. We get patients up and walking the same day of surgery. Typically, it's usually an overnight stay for a 1 or 2-level fusion. And so it's very rapid. There are some patients that want to go home the same day, and we still just haven't broken out of just sending patients the same day, but typically it's a 1 or 2 day stay in the hospital at most for just a couple level fusion. The typical course, as I mentioned, we get you up and walking the same day. I want patients walking at least a mile a day shortly after surgery. Typically, at first, that's 4 to 6 short walks a day, building up to a mile, but should be able to walk a mile a day shortly after surgery. Typically, for a fusion patient, I do limit your activities for lifting. I don't want you doing much heavy lifting for the first 6 weeks. Walking for the first 6 weeks, and then usually start formal physical therapy at the 6 weeks marks. For a fusion, typically I do not want impact activities, running, jumping, skiing, for usually 6 months. As I mentioned earlier in the presentation, sometimes that's not the case, and I know I have patients that get after it much sooner. That's kind of the typical course of recovery following a fusion procedure.
So thinking about activities that people do around here, skiing, climbing, what's the time range you would expect them to be able to get back doing those things? Biking?
Yeah, most things, so biking, if you're on the bike path and whatnot, not doing downhill mountain biking, I'm okay with that at a couple months after surgery. But most impact activity, I would still ask 6 months. A fusion of the neck is a little bit more riskier for downhill activities, high impact, than a fusion of the lumbar spine. But nonetheless, it's usually 3 months for most activities that aren't high impact or high falls risk, 6 months for others.
And what about someone that's been told they have osteoporosis? Are they a candidate for surgery?
That's an excellent question. So it really depends on what type of surgery. As I mentioned earlier, decompression surgery, you're not putting instruments in. Someone who has osteoporosis, you can remove bone for decompression and it doesn't affect their outcome. But if you're doing a fusion surgery where you're relying on screws and rods or implants to hold the spine, and if the bone is not of good quality, that instrumentation may not do its job. And so if someone has significant osteoporosis, they should not have a fusion surgery unless the osteoporosis is treated. And in particular, if we're doing a long segment construct, multiple levels, say if someone has a large scoliosis, a DEXA scan is done for every patient before a massive surgery like that. We treat them if they have osteoporosis, just because the outcomes have shown that if you have poor bone quality, the screws do not hold. If you just have a 1 or 2 level fusion, you have some osteopenia, you're not reached the osteoporosis segment, the outcomes are still quite good when you have this 360-degree construct, but that needs to be discussed with a case-by-case basis to look at those.
So don't give up hope.
That's right.
So say someone's had a back surgery in the past and also a recent hip replacement. Maybe it was a right hip replacement and they're still having some pain down the lateral side of that thigh. Could it possibly be the back versus the hip? How do you decipher hip versus back?
You bet. So commonly I see patients that have some shoulder pain and they think it's their shoulder and it turns out to be the neck, or vice versa. And commonly hip pain can come from the back or the hip itself or other etiologies. And so there's a lot of overlap in between those. And my partners, my shoulder partners, my total hip partners, we share a lot of patients many times. It can be both. There are some telltale signs. If something's radiating from the back down below the knee, that's usually a back. If someone has difficulty with balance, hand dexterity problems, and still has a lot of shoulder pain, you need to evaluate the neck. So there are some key factors in those conditions, but there is a lot of overlap, and many times you can have, I say when you take a dog to the vet, it can have ticks and fleas. You can have 2 separate entities that are still a problem for that individual, and so sometimes you can have both.
Yeah, so how do you pick which one to address first?
That's a great question. So it depends on, so let's take, for example, the lumbar spine. If someone has a deformity of the lumbar spine, say a scoliosis, plus a bad hip, typically we fix the spine first because that spine can be realigned and change the pelvic anatomy. And when you change the pelvic anatomy, that's important when you have a hip replacement. Studies have shown if you do a hip replacement before you do a big lumbar correction, you may have increased risk for a dislocation of the hip because you change the pelvic alignment with the lumbar surgery. So if someone needs a larger lumbar procedure that may change their pelvis alignment, it's appropriate to treat the spine first. That way you minimize the risk for hip dislocation. If someone has normal spine alignment and the hip bothers them more, treat the hip first if it's not going to be a procedure that will change the pelvic anatomy. So typically you go to the one that bothers you more if it's not going to affect the pelvic alignment.
When it comes to a fusion procedure, how do you know it's time?
As I mentioned, most of these are elective. I tell patients that you're going to like me a lot more if we can treat you without surgery and get you feeling better. But ultimately, it's a quality of life decision. If you've gone through conservative measures and you're not doing the things you want to do, the activities you want to do, and you're finding you're having more bad days than good, then quality of life, most of the time we can improve with spine surgery if you have the appropriate indications and you've failed conservative measures. And so patients typically say, boy, I wish I didn't wait as long as I did, but nonetheless, if you're having more good days than bad, don't have spine surgery. If you haven't had conservative treatment, for the majority of cases, go through that, and hopefully we're able to get you feeling better without surgery. But ultimately, do not let it rob you of your quality of life if you're not doing the things you want to do and you find yourself not being as active as you want to be. And that's one of the things I enjoy practicing here in Jackson in this region, is that people want to stay moving. I have just dozens of 80-year-old patients that are skiing more days a winter than I am, and they want to stay active and keep moving. And so that's the purpose. And I think that's important when you speak to your surgeon, that you're on the same page, because how one surgeon defines a success or how one patient defines a success might be different. And so you want to make sure you're on the same page and you have the same expectations to what is successful and can we get you to that point.
So if I have spinal stenosis, is a lumbar fusion my only option, or are there other things you can try before you go to the full-on fusion?
Yeah, you bet. So stenosis is just a general term for narrowing. So when you have spinal stenosis, you can have narrowing around the nerves, and that can be in multiple areas. It can be in the middle of the canal, it can be where the nerves exit out, and it can be caused by a number of reasons. It can be caused by a disc herniation, it could be caused by wear and tear, and you get some arthritis where you get bone spurs and thickening of ligaments that cause it. It could be caused by instability. So if you do not have an unstable spine or signs of instability like the scoliosis or what's called spondylolisthesis, where you have one vertebrae that slips on another, you can just do a decompression where you open up the canal. Some call it the roto-rooter, or a laminectomy is the technical term for it. That's where you make a tight canal, kind of a U-shape, by removing some of the bone, the lamina on the back of the spine. And so if you do not have any signs of instability, that's a very reliable way to treat it. The recovery is not as big as a fusion, and it's very reliable in helping the leg pain. If someone has stenosis secondary to some of those other conditions, scoliosis, a slippage of the spine, then we do that fusion to stabilize the spine to eliminate that stenosis.
Probably one of the most common things you see in our community with all the young active people is a herniated disc, right?
Yes.
What do you do about that?
You bet. I will tell you the majority of disc herniations get better with conservative treatment. Again, the red flags to look for: if you have progressive weakness, if you have intractable pain, if you have anything that's causing difficulty with bowel or bladder function, those are red flags that you need to get evaluated for. But the majority of the time, they get better on their own. The body does have the ability to kind of resorb the disc herniation in and of itself. And so what the disc herniation is, you have two parts of the disc. You have a thick outer layer that's called the annulus, and the inner layer is called the nucleus. And you can think of it almost like a jelly-filled donut. So you have an injury to the outer layer, and the inside squirts out. And so when that material squirts out, it usually pushes on a nerve, and that's what causes the leg pain. And so ultimately, you can treat it with therapy, injections, giving it time. If those things do not help, then you can go in and do what's called a microdiscectomy. Micro meaning just through small incision, you go in and take out that fragment that's pushing on the nerve. I probably operate on only 1 or 2 out of 10 disc herniations that I see. The majority get better on their own through conservative treatment. But if you have any of those things I discussed, progressive weakness, intractable pain that doesn't get better with those conservative measures, or if you have any of those what we call cauda equina symptoms, where you have loss of bowel or bladder and numbness in your groin area, those are ones we treat aggressively with surgery up front.
What about, over years, you've heard about laser spine surgery, and it sounds like you don't even get an incision and they can fix things. What is that?
For the most part, that was a very clever marketing scheme. The Laser Spine Institute went out of business, I think, 2 or 3 years ago now. They would still do a decompression, typically, just through a small incision to go in and free up the nerves. And then the laser was used to do an ablation or a burning of the nerves that go to the joints, the facet joints. And so that was done on every patient, whether they needed it or not, as part of their marketing scheme. And they treated a lot of patients. The decompression is really what helped the patients the most. The rhizotomy, or the ablation of the nerve, didn't do a whole lot, but that was a pretty clever marketing scheme. There are some lasers that are used to that do ablate the disc herniations. But there's not something that just zaps stenosis or zaps instability that treats spine conditions.
Do you see any new technology coming in for stuff like that?
There is certainly a lot of research that's being done. Endoscopic surgery is becoming more at the forefront, where we're using, in the military, I did a lot of arthroscopy, and where you're putting in small cameras into joints, Endoscopy is where we're using small cameras to go in and look at the spine. And so that's something that's evolving. It's not to the point where it's commonplace and can be used on a lot of spine conditions, but that's something that's evolving, and we hope that there's more coming down the road. Navigation will play a part in that, because many times if you can navigate and see on a computer-generated image where that condition is, you don't have to, you can go right to it with endoscopy. So that's something that will ultimately play out as this technology advances.
It'll be interesting to watch, won't it?
Absolutely.
The only other thing that someone was asking about is, what is the treatment for a compressed or a collapsed disc or a fractured disc vertebrae?
Okay. Most commonly, for someone who has osteoporosis, you can have a compression fracture. That's a fragility fracture, just like a hip fracture. You know, it was very common in the past to do what's called kyphoplasty, where you go in and put a balloon in that bone to try to open it up some. It creates a cavity, and then you fill that cavity with a bone cement. That's still a procedure that is done. It's not as wide, as commonplace as it used to be. We found that ultimately, if you can get through that first 4 to 6 weeks of pain from a compression fracture, you get better, and if we can save you a procedure, great. But it's still a very reliable procedure to help patients that have a lot of acute back pain from a compression fracture. Compressed disc is very commonplace. As we age, you get degeneration of the disc, and usually you don't treat that aggressively until you get nerve symptoms, and so that's when other modalities come in for treatment if you have nerve symptoms from a degenerative disc. Disc replacement is becoming more and more useful. It's commonly done in the cervical spine, not as common in the lumbar spine, but that is a condition if you just have a compressed vertebrae without instability, and if you're appropriate age and candidate for it, a disc arthroplasty or replacement of that disc is becoming much more prominent.
What are things our young, healthy, active community can do to help protect their spine in the future?
Well, you know, just knowing that spine care is multifactorial, meaning that there are a lot of different things that add to degeneration of the spine. There's definitely a genetic component to it, and so some people are just dealt a bad hand when it comes to genes of the spine. But as we, you know, I got a text from a senior in high school recently that said, "Hey doc," he's a friend of a family member, that he said, "Doc, I was doing a backflip in the park last week and I hurt my back and it's just not getting better." And you know, that's unfortunately, he ended up having compression fractures as a senior in high school. And so we just have to know that many of these things are additive over a lifetime. And so the things we can do, there are only so many modifiable risk factors. Those are the high impact activities, injury, our weight, our core strength, our body mechanics. Nicotine, as I mentioned earlier, is a significant risk factor for spine health, as well as diabetic control, diabetes control. And so as you work on those controllable risk factors, those are the ones that we can control. We can't control, you know, our genes. We can't control, you know, certain wear and tear, you know, just through our jobs and whatnot, but having good body mechanics, good core strength, good weight, good posturing, all those are important through a lifetime, just not, you know, as we get older, but starts when we're young all the way through when we're older.
Yeah, helpful to hear, thanks.
Absolutely.
Any other questions you can think of that are common that we didn't cover?
You know, I think this is very beneficial. Feel free again, if you have any questions, call our office and we have emails that you can send questions into. But I hope this was beneficial for everybody. We'll look to do more of these in the future. And this also will be available for a refeed through links through St. John's Health, through their website and other social media. So we'll go from there.
Thanks again for joining us tonight.
Thank you, everybody. Have a good night.